CD16 Indivisible, who is one of the co-sponsors of tonight's group. There are many co-sponsors, and we'll make sure to cover that shortly. But what we'd like to do, and like to say welcome to the 28 of you who are on with us already, and we assume that we'll be more joining within the next 5 to 10 minutes. We'd like to begin this forum tonight, which is going to be a discussion about the New York Health Act, and really from the most positive framework that this can happen at this moment in time. We'd like to just go ahead and get things started by running about a 6-minute video that was recently published in the New York Times that I think will go a long way in setting the stage for why not only can the New York Health Act happen now, but why it must happen now. So Liz, I'll let you take it away and get that video started.
Eileen, can you see a video?
Nope.
If healthcare is a constitutional right, then
that's a form of communism because no country could have.
Can you see the video?
No.
We can hear, but we can't see, Liz.
Okay. All right. Sorry. Let me do that again. Okay. I am going to stop the share.
And you have video and audio optimized, I imagine.
I do. Oh, shit. What did I do here?
For folks who just joined in the last minute, Liz is just going to set up a video for us to get things started tonight. A year and a half later, we're still fighting with Zoom. But we won't give up the fight. Zoom won't win. We will win.
if healthcare is a constitutional right, then
That's a form of communism because no country could afford those payments without seizing the assets of everybody else.
Welcome to Finland.
Oh!
Dudes, what's going on? Oh my god!
It's making me so mad.
I mean, come on, guys. It's not that hard. Look around the world. Everyone else seems to have figured it out, right? Imagine you're in America. Which of these options would be best for you?
That's a lot to think about.
What is it? An OOP max?
I guess with what I got here, I would go with Plan D because the deductible is 0.
Okay, there's more.
Gold, HMO, PPO, HMO.
And what are copays? I don't get. That's like if you pay for Spotify Premium and Spotify still makes you pay every time you listen to a song.
It's too complicated.
I'm lost. I'm so lost.
In Canada, I don't have to really think about the different plans that I could pick from.
You just pay one amount per month and all the major treatments are covered.
At least 70% of our medical expenses are always covered.
Uninsured, unable to afford treatment for a tooth infection that keeps flaring up. Cook Emma Rittner lost her job in March.
I did manage to get antibiotics from a friend whose mom regularly goes down to Mexico, and I've been taking that self-medicating based off of Dr. Google's advice.
Dr. Google's advice.
Here in Japan, even if you lose a job, you would never lose your health insurance.
When you lose your job, that's when society should help you.
I've chosen a creative job and had the backing of a healthcare system. But if you don't have that, do you pick the safe job or do you pick the creative job?
The average price per unit for insulin in 2018.
Germany, $11.
Canada's $12. Wow. It's like 8 times the price of insulin in Canada. I guess that explains why Americans come up to Canada to buy medication.
I'm sorry, hold on. So the FDA doesn't have any authority over the prices?
We have also privatized health insurance companies in Germany, but the prices are regulated by the government.
The government negotiates the prices and fixes that price for 2 years.
In Singapore, they regulate this stuff to keep the prices down and, avoid like this happening.
Right, so I'm looking at an American medical bill.
Why is it so expensive?
$428,000 for rooms and such empty spaces. What?
Much cheaper to go Hilton Hotel than this one.
Skin to skin after a C-section is $39.
I had to pay $39.35 to hold my baby after he was born. You need to pay money to hold a baby?
My brother Jamie, who's in a lot of our videos, was pretty badly injured. He's going to lose a couple fingers. If you can give $1 or if you can give $5, every little bit will help him and his family.
That's heartbreaking.
GoFundMe should not be something that people have to resort to pay for their medical bills.
So in America, people spend more than twice as much as in Japan for healthcare.
If I paid twice the amount for a car, I would want the car to be twice as good.
So what's the life expectancy in the US?
Why is it less?
The US should be on top of both of those lists. Like, if you're charging your citizens that much money, then they better be living the longest lives. It doesn't make sense.
When Alec turned 26, he was no longer allowed on his mother's insurance plan. Instead, he decided to pay for his insulin over the counter at list price. But the pharmacist told him a month's supply would be $1,300. He left empty-handed. Alec's official cause of death was diabetic ketoacidosis.
A couple of years ago, I developed a heart condition, and I had to have my heart restarted 3 times. After the 3rd time I had it restarted, the doctor suggested I get heart surgery.
When I was 13, I started to get sick and really, really sick. I was then very quickly admitted into hospital, where after 3 weeks I had treatment for a brain virus.
The cost of the operation, I think, is about $60,000. And then the next day, when I left the hospital and I got my bill, it was a bill for parking. It was about $30.
And was treated by royal doctors, had several MRIs, lumbar punctures, all for free.
So I was pretty happy that I lived in Canada and had universal health care.
I couldn't have survived if I was in America.
To know that I can get sick, I can get injured, but I will still be taken care of. That is freedom. This is not freedom.
I'd like to welcome everyone this evening. If we can go just back to the title slide, Liz, that would be great. I'd like to just welcome everybody this evening to the New York Health Act Forum. And I hope most of the 37 folks who are on had a chance to watch that video with us. And before we get into the meat of this, why doesn't everybody just take a quick minute and put 1 or 2 words in the chat about how that video made you feel? What's the first word that comes to mind after watching that video? Outraged, angry, furious. Myra's heartbroken. Maura's angry, hopeless and helpless, disgusted. Our for-profit system has to go. So it is a powerful 6-minute piece. And yeah, there are moments that are somewhat amusing and funny. It's incredibly powerful. But I think most of the emotions that it brings up are ones of disappointment and sadness and rage. And just the utter ridiculousness of the system within which we live. So we want to welcome you all here tonight. We're at a particular moment, a pivotal moment in the life of the New York Health Act. My name's Andrew Mutnick, and I am a member of the steering committee of NYCD 16 Indivisible, one of the organizers and leaders of this event. So many groups have come together to co-sponsor this tonight. I just want to take 15 seconds to really highlight and tell you who they are. In addition to NYCD 16 Indivisible, Seco Hope Indivisible, CD 17 Indivisible, Indivisible New Rochelle, Hudson Valley Demands New York Health, Indivisible Scarsdale, Indivisible Yorktown, New York, Indivisible Westchester, IW 6 and 7, Northwest Bronx Indivisible, NIPAN, Progressive Women of Pelham, Putnam Progressives, Rivertown's Vote, Uptown Progressive Action, Westchester Citizen Therapists, the Westchester Black Women's Political Caucus, and the Hispanic Democrats of Westchester. So an incredible coalition of groups coming together and wanting to really move this bill across the finish line, and certainly wanting to participate in an educational forum where we can learn more both about the bill and how we might influence its passing. So thank you so much to our co-sponsors. We've got amazing panelists tonight. We do have some sad news. We heard from Senator Rivera, and unfortunately he will not be able to join us tonight. You know, I'd hazard a guess that he's fighting tooth and nail to get his bill on his committee agenda for tomorrow. But he's doing something, we know, affiliated with this legislation. And unfortunately, at the last minute, he's not going to be able to be here with us. We're hoping that Assemblyman Dick Gottfried will be with us this evening, Peter Arno, a health economist from UMass Amherst, and Judy Sheridan Gonzalez, who's the president of NYSNA, also will be with us this evening. So we thank them in advance. We're really looking forward to hearing from all of you. We thank you in advance, not only for being here, but for all of the tireless work over years that you have been doing to work towards this health justice piece of legislation. I just want to, I'm a pediatrician, and so I just want to tell a quick story that resonates for me as we come together to talk about healthcare in our state and in our country. Last week, I saw a 2-month-old who had come in to get their first set of vaccines, and the child was a little bit ill, and it turned out that she had a fever. And when any unvaccinated baby younger than 2 months of age has a fever, you have to take it quite seriously and make sure that there's not a serious bacterial illness that's the cause of the fever. And as I had the family in the office and was sort of taking them through those paces and saying, listen, it's going to be important for you to go into the ER to have an evaluation. My guess is everything's going to be fine, but it's your baby and we have to make sure that there's nothing going on. She understood and she shook her head and she said, of course. And then she said, but you said everything's going to be fine and that she'll be able to go home. I said, I think so. Yes, I think so. That's the good news. And she said, but if she doesn't get admitted, then I have a $500 copay. So that's where we are right now. Doesn't make any sense, does it? That should be what a new mother is thinking about when the best thing and the only thing for her baby is to go to the ER to have a workup. She's even thinking maybe I shouldn't do that because I'm going to have to pay for it. So that's one among many, many stories that I'm sure many of us have and many of us could tell about what's broken in this system. So what we'd like to do, I see Assemblyman Gottfried is here with us tonight. Thank you so much for being with us. What we're going to do is we're going to hand off to each of our distinguished guests to talk for about 10 minutes or so about some aspect of the bill. In Assemblyman Gottfried's piece, it's going to really be to let us know what this bill is. This is in many ways his bill, introduced over 30 years ago. For those of you who don't know Dick Gottfried, he represents the 75th Assembly District in Manhattan. covering the neighborhoods of Chelsea, Hell's Kitchen, Murray Hill, Midtown, and part of the Lincoln Center area. And I'm sure you all know that he is the chair of the Assembly Health Committee and has been so since 1987. First elected to the Assembly in 1970 at the age of 23. I think you were a student at Columbia at that time, and is the longest serving member in the state legislature. He is responsible for rafts of legislation focusing on civil rights, human rights, and healthcare. We are so thrilled to have you here with us this evening, Assemblyman. And listen, who better than to tell this group what is the New York Health Act and the who, the whats, and the hows of coverage. And we look so forward to hearing your comments.
Well, thank you very much. It's terrific to be here with you. So the New York Health Act is a New York State single-payer health plan. A lot more people know the word single payer since Bernie Sanders brought it to the national attention than back when we first put the bill in. It's a system of publicly sponsored, publicly accountable, publicly funded health coverage that would, first of all, cover every New York resident, rich and poor, however you got here, whenever you got here, you could have fallen from the sky, every New York resident would be covered. What would be covered? Everything. It is the most comprehensive collection of benefits in any plan that I've ever heard of. It covers any healthcare service or benefit that would be covered for anyone by either Medicaid or Medicare or the state public employee health package or the mandates of the state insurance law or anything else that the plan might choose to add. Most significantly for a lot of people, certainly in terms of what most of us are not covered for, is long-term care, whether it's home care or nursing home care. The vast majority of New Yorkers have no coverage for that. And as a result, when a member of the family needs long-term care, chances are either the family's lifetime savings are going to be wiped out if they have savings, or a member of the family will have to give up her career or a large part of her life. And in our culture, it is usually a woman in the family in order to care for the ailing loved one. And none of that is right in a civilized society. The way it is, well, those are the benefits. It is not funded through premiums or out-of-pocket charges like deductibles or copays or out-of-network charges or any of the like. Instead, and by the way, there are no out-of-network charges because there is no restricted provider network. Every healthcare provider would be welcome in the network. And the way we do fund it is through a broad-based, progressively graduated tax on income, whether earned income like wages or unearned income like dividends and capital gains and the like. Income that comes from employment, your employer would pay at least 80% of your share of the tax on your income. You would pay up to 20%. In collective bargaining situations, especially, the employer might well be paying anywhere from 80% up to 100%. And progressively graduated means your lowest chunk of income would be either tax exempt or at a very low rate, and then if you've got $100,000 or $1 million, those would be taxed at a higher rate, as I think they should be. Everyone's first $25,000 of income would be tax exempt. And if you're on Medicare, your first $50,000 of income would be tax exempt. largely in recognition of the fact that if you're on Medicare, you are bringing a huge chunk of money from the federal government into New York State, thus essentially contributing to what we would be spending under the New York Health Act. So those are the basics of it. People often ask, well, how much is my doctor going to get paid? Doctors tend to ask that question. How much will my hospital be paid? And the answer is, unlike every other health plan, this bill has criteria built into it guaranteeing full and fair payment for healthcare services. And people say, oh, are you going to pay us all, just like on Medicare or Medicaid? And everyone knows they don't cover the full cost, and doctors and hospitals will go bankrupt or they'll leave New York. Well, we've covered that in the bill because the bill has language that declares that we recognize that Medicaid and Medicare do not pay for the costs of care, do not pay a sufficient amount to guarantee an adequate supply of a care, and it mandates that the New York Health Act will pay well above and beyond what Medicaid and Medicare pay. People often want to know, how are we going to pay for it? And the answer is, well, part of the answer is, how do you think we can pay for the current system? And the answer is, a lot of care doesn't happen because we can't pay for the current system, especially for people who aren't really rich. But the key way we are able to pay for covering everyone and eliminating deductibles and paying fair price for all healthcare is with the $55 billion in savings that we will get, at least that much every year. Savings from what? A big chunk of it comes from taking insurance companies out of the picture and no longer spending what we now spend on their bureaucracy and marketing and profit. And doctors and hospitals will spend dramatically less than what they spend today on the administrative costs of fighting with insurance companies. And finally, a big chunk of the savings is what we get from having the bargaining clout of 20 million consumers, all people in New York, to bargain prices down with drug companies, like nobody has the power to do today. Put all that together, you've got fair funding, no out-of-pocket costs, fair prices paid to every healthcare provider, who will almost without exception be doing a lot better than they actually are today. And we fund it by fair taxation and redirecting money from tens of billions of dollars in waste and putting that money into healthcare, and some of it actually back into people's pockets. So that's the pitch about the New York Health Act. I'd be happy to take questions about it if you like.
So, Assemblyman, thank you so much for putting us firmly on the ground here and letting us know how this will work and how it will be paid for. I think what we're going to do is hold some questions. I'm hoping you can remain with us for a while.
Yep.
Okay, great. But maybe before we pass it off to Judy Sheridan right now, it just might be a moment, if you want to take a moment or two and kind of reflect where we are right now. You introduced this bill 30 years ago. And maybe you can just talk for a minute or two about what's special about this moment. What is it that I think there's a lot of promise in this moment right now, and maybe you can reflect on that.
Well, a couple of things. One is elections have consequences. And between the 2018 and 2020 elections, we now have in the Assembly, well, we've long had in the Assembly way more than a majority of members as co-sponsors on the bill. That goes back to the very start of the bill. For the first time in history in the New York State Senate, we now have a majority of the members of the Senate are co-sponsors of the bill. So if we can get the bill to the floor in the Assembly and Senate, the votes are there committed to pass the bill in both houses. And the other thing about this moment, I think, is that the COVID pandemic has really made clearer than ever before. I mean, it was always pretty clear to a lot of people, but more clear than ever before, the outrageous inequities and disparities in our healthcare system resulting from the way healthcare is paid for. You know, if in my district in Manhattan, which is one of the wealthiest districts in the state, or probably in the country, if somebody has a heart attack or comes down with COVID or has a baby, they're most likely going to end up in one of the finest medical centers on the planet. But in an awful lot of New York, you're going to end up, if you go to the hospital, in an understaffed and underfunded, quote unquote, safety net hospital. And the reason is because our healthcare system doesn't pay for the true cost of caring for people on Medicaid or Medicare. And people who aren't very wealthy are more than likely than not to not only have a health plan that has massive deductibles and copays and a very restricted provider network, but you're more likely not to be able to cough up the money for that deductible or the copays or for the out-of-network charges to go to the doctor or hospital that your doctor would recommend for you. And those disparities have been with us for decades, maybe for history, but COVID has made those disparities clearer than ever. And under the New York Health Act, you know, the gallbladder of somebody with the most gold-plated health coverage is going to be worth the same as the gallbladder of somebody who's on Medicaid or who can't cough up the money for their deductible. And the surgeon who takes out their gallbladder, if that's what you do with gallbladders, I don't really know, will be fully and fairly paid regardless of whether that patient is rich or poor. And that's how the New York Health Act, how the disparities, what we've seen from COVID, really highlight a lot of the need for the New York Health Act.
Thank you, Assemblyman. Yeah, so it is a political moment and a moment of health equity and justice moment that hopefully will take us to the promised land. Thanks so much. Please stay with us. We want to go through some case studies with you. There are questions piling up in the chat, and we'd just like to give Judy Gonzalez now a chance to speak with us. For those of you who don't know, Judy Sheridan Gonzalez is the president of the 40,000 member New York State Nurses Association, or NYSNA. It's the largest, New York's largest nurses union, and she's worked for more than 30 years as a nurse on the ground at Montefiore, and she's worked in a variety of other specialties as well, and in different healthcare environments. And she is part of an active group of nurses engaged in transforming the organization into a social justice union, pledged to participate in uniting labor and community in order to construct a movement dedicated to combat inequality and committed to social change. And Judy, we thank you so much for all the work that you have done. And we're hoping that you'll give us the perspective of what this means on the ground as a healthcare provider, as a nurse, and also the perspective from a labor leader, as we know that there are different perspectives and that there are labor unions, both rank and file, and labor leaders who may be on different sides of the divide around the New York Health Act. And we're hoping that maybe you can help us to understand that and to see how there may be a coalescence that will help make this legislation happen. So thanks so much for being with us tonight. I pass it off to you.
Okay, thank you so much for inviting us. So the nurses in my union, as the assemblyman said, realized years ago that this current health system wasn't working, and that's over 30 years ago. It's so much worse now than it was then. I don't think anyone dreamed that we would be spending so much of our time billing patients instead of caring for them. And if you talk to any healthcare worker or provider, that's basically what we're doing now. This thing has gotten so out of control with the for-profit system that it really matters very little what happens to patients. What matters is how they're billed. And that is something I think anyone sees. You see, when you see a provider, we're all looking at computers, or we're looking at phones, or we're looking at gadgets, or we're scanning you, or, you know, we're not even looking at you while we're typing, we're checking off boxes. All these things are designed to make sure that you get billed. That is crazy. And many of the new nurses coming into the profession are so tethered to computers that they can't, many don't even know how to do physical exams. This EMR system that we have, which we thought was going to make life better for us, really serves as a distraction. In fact, when we used to write our assessments of our patients, there were independent assessments. I absolutely am sure that many practitioners just copy over what somebody else wrote. They copy and paste it onto their own notes. I see it happen all the time. So this issue that people are looking at, and other unions certainly are looking at this, that they think that they have really good health care, it's absolutely a myth. The IOM, the Institute of Medicine, estimated about almost 500,000 of deaths in the country due to medical error. We see these errors all the time. And of course, we have HIPAA regulations that prevent us from discussing them. But definitely there are so many errors that are made because people are so distracted with all the other things that we have to do, and the understaffing and the under-resourcing that is now occurring in healthcare as a result of this cutthroat race to profits. So we understand that there's so much savings that could be had if we got rid of the insurance companies, which would get rid of the marketers, the consultants, what we call the bean counters, all the people making clinical decisions who are not clinical. They're making decisions based on a variety of sources. And why I say even, I know Mr. Gottfried had said, well, if you go to a hospital in his district, you're going to get the best care. Guess what? You're not. That is not true. It's a crapshoot every time you go to the hospital. If you talk to any nurse, or probably many physicians, but definitely any nurse, if we have a family member that gets hospitalized, we have an army of people there to care for the person in whatever way we can. Even if you work in a so-called not great hospital, you want your family member there because you know that you have access to monitor what's going on, because it's become so impersonal. It's become so, and COVID really has made it much worse because you can't even properly advocate for your patient. Why would anybody not want this? Well, I read the rationales that the other unions have put forward. One issue which I think has merit, let's put it more, let's encapsulate it in this sort of Trump 4 years that we've lived, where there's such distrust of government, there's such distrust of institutions, and for good reason. I think we had good reason to distrust our institutions and our government. During COVID, the beginning of COVID, we had a lot more reason to distrust the CDC and all the other guidance that was provided for us because so much was political. So people have a basic distrust. They like to know what they have. They like to know that they have control. And when they don't have control, it's frightening. People always say the better the devil you know than the devil you don't. So I think that the issue of this commission, I've heard a lot of concerns about the administrative panel in the bill, that people feel that there's not going to be appropriate representation. There's a lot of appointments by the governor. There are certain people with feelings about the governor, feelings about the health commissioner, who's also appointed by the governor, and other people that would be on this commission that may not represent the interests of members of unions. But each group of, mostly it's public employees, because 1199 and NISNA are, although we represent public employees, we've come out in favor of the bill, but some of the public unions seem to be pretty much against it. They all have a disclaimer that they agree with the concept of single payer. However, and then there's a lot of buts. Well, to me, if you agree with the concept, then you shouldn't oppose a bill. You should say, let's amend the bill. Let's address the bill in this particular way. There are some who are saying that they want to carve out, and I think the assemblyman can talk a little bit more about what that is. That is a problem because we then create a two-tier system. They don't like the idea of having to pay a payroll tax because many don't pay premiums, although many do. There's the hidden cost of healthcare, because when people don't get the care that they need because of the nature of the healthcare system, that they can't get services, they can't get a treatment, they can't get a particular drug, they have to go to a particular physician. A lot of people pay out of pocket, even if they have this insurance, because they don't want to be subjected to those services. So they are paying. The other argument that is made is that they've lost wages and lost other benefits over years by funding their healthcare through the employer through collective bargaining. And that to now pay a premium when they never had to pay one before through a payroll tax is unfair. Well, there's two pieces there that I think are troubling to me. One is that, yes, you did this when there was no single payer healthcare. So that was the quid pro quo to get healthcare then. Now that there is, you don't have to do that anymore. You're going to have healthcare and the employer is going to pay 80%. And you can actually negotiate away that 20%, because when the employer was paying $21,000, $22,000 for a family plan, and now they're just paying $12,000 and they're actually paying 80%, you can negotiate that the 20% is paid by them and you won't be paying a payroll tax. So that doesn't make sense to me. And this argument about what you did all these years to get what you have now, you know, we did a lot of things. we had in our contracts certain types of paid family leave, and now we're paying a payroll tax for paid family leave for everyone, and it's a better benefit. I think it's the same thing with the single payer plan that in the New York Health Act. The third thing that I hear from employers all the time, and certainly from unions, is this should be a national plan. It shouldn't be a state plan. And that's this whole concept of all or nothing. I mean, we can wait a long time for a national plan. Look at the country. Half the country voted one way, half the country voted another way. The half that voted one way is, I don't want to get into it, but perhaps those people would not support such a system. So you have to start somewhere. Maybe we can look at something regional, look at New Jersey, look at Connecticut, look at Massachusetts, Vermont, it can mushroom out. That's what happened in Canada. So those arguments don't make sense to me. I do think that the thing that bothers me the most about some of the objections is, instead of saying we oppose this, there are all these problems in it, I think it's say we really want this to work. We really want this for our members. We want this for our communities. We want this for everybody. We have so many people that are now unemployed that don't have insurance. What about those members that have lost their jobs? They don't have insurance. They used to be your members. So let's talk about what we can do to really make this work. Let's figure this out. I wish that was what I was hearing instead of this is no good. So I don't want to rush to judgment about why that might be. I do think there are fears, there are conspiracy theories, and people don't trust government processes, and there are good reasons for that. But I think that this is something that we really need to have to work out together. And particularly this issue of the savage inequities in healthcare that we see all the time. Even though you can't trust any system, it is so much worse when you don't have the resources and the staff. I work in an emergency room with an academic medical center, but we service very often a poor population. Instead of taking care of the 4 or 5 patients, that is something that is a respected number, I can take care of 15 patients at a time who are sick. It's not a possibility. And that's because there's not enough funding for healthcare, because so much is skimmed off the top by this rush for profits, or decisions are made about physical plant, about procedures, about protocols, about staffing, about everything that is involved in healthcare that is not built around clinical needs or moral needs or ethical needs or any of the things that really matter. They're based on how you're going to save money and how you're going to make a profit. So, we've been willing to work with anybody that we can to make this work. And I just think it's something that we have to sit down together and walk through all the kinks to make it better.
Judy, thanks so much. Really, really appreciate all of your advocacy and your work and your sort of crystal clear understanding and education and explanations to us about what you see. Quick question, which is, obviously you've worked for a long time in the ER, so you know hospitals, you know systems. You've also been and are a labor leader, so you know hospitals and you know systems and you know big, powerful academic systems. And maybe you can talk just for a minute or two about what we can expect from those big systems in terms of how they're going to deal with the potential passage of a piece of legislation like this. Well,
In my conversations, again, the irony of this is everyone you talk to says, I support the idea. How is it that something doesn't happen when everybody likes the idea? What's missing here? And I think these academic medical centers, they get a pretty good deal with the way health insurance pays. They get paid more than public facilities, and everybody here gets paid way more than they do in Puerto Rico. So how does it work that you have different pay scales for different levels, different levels of hospital? It's crazy. So they have figured out how to make money out of the current system. And, you know, I had a conversation with one of the CEOs, and he said, look, I totally support this. But my job is to ensure that my institution thrives. And my institution, I figured out how to make my institution thrive right now so that we can provide care. I think that's going to be compromised. I worry that that'll be compromised with a different system. So you're doing well at the cost and the expense of these smaller hospitals, these rural hospitals, as Richard said, you know, the ones who are safety net hospitals, the ones who have safety net populations, and that's okay. That's okay, because that's not your responsibility. You're talking about a business. You have a business model where you want to protect your business. You don't even have stockholders, because we have kept the for-profits out of New York in hospitals, not in nursing homes. And now we see what happens when you have for-profits in the nursing home is much, much worse. So they're resistant, I think, because they make a lot of money, and they have hired. If you look at the numbers of people providing care in hospitals, that has leveled off over the last 30, 40 years. You look at administrators, that's gone up like a mountaintop. That's like that level, you know, that the COVID that we saw in April last year, that's what it looks like with all these administrators. So they're paying all this money. People are making so much money, not just insurance companies, but actually in these hospitals, in these not-for-profit academic medical centers, there's hundreds and hundreds of people in each medical center that never even existed before. That are making a lot of money. So there's a lot of people with interest not to change that. When those resources could be spent on caregivers, enough staff to care for patients, physical plant that's improved, better programs for our patients, outpatient care, addressing the social determinants of health, and all the things that make our population healthier. So it's crazy. Yeah, people resist because they get something out of it.
Thank you, Judy. And in many ways, that was a perfect segue. And we hope you can hang out as long as you can. I understand you have to get to something else.
8 o'clock.
Okay. All right. Thank you for being with us. And thank you for all the work that you're doing on behalf of all of us and for this New York Health Act. And that was in many ways a perfect segue into Peter Arno, who I think is going to show us in graphic terms what that looks like in terms of the healthcare workforce and the administrative workforce and what's going on in terms of growth in those areas. For those of you who don't know Peter, he's a senior fellow and director of health policy research at the Political Economy Research Institute at UMass Amherst. He's a member of the National Academy of Social Insurance and serves on the board of directors of the National Committee to Preserve Social Security and Medicare Foundation. He wrote a book in 1992, Against the Odds, the story of AIDS, drug development, politics, and profits. That book was nominated for a Pulitzer Prize. Peter, we've asked you to describe the economic underpinnings of the New York Health Act. You know, I guess, or phrased otherwise, how in the hell will we pay for this, and what's going on in our health system right now from an economic perspective? Thanks so much for being with us tonight.
Good evening, everybody, and thanks for inviting me. I'd like to just do a real quick overview of where we are right now with the cost and insurance coverage, and move to the financing and the cost of the New York Health Act. So if we could move to the next slide, this just shows you very simply how working Americans fare in our current healthcare system. So remember, this is the group that pundits keep telling us really hate to give up their private insurance for a radical idea like Medicare for All or the New York Health Act. The two top lines shows the increase in deductibles and insurance premiums. The two bottom lines are workers' earnings and overall inflation. What does this tell us? Well, over the past 10 years, premiums have risen more than twice as fast as earnings, and deductibles more than 6 times as fast. Next slide. So this is just a quick look at drug prices. A very recent study by the Rand Corporation found that brand name drugs in the US were nearly 3.5 times more expensive when compared to 32 other developed countries. So the bar on the right, 344, drugs in the US are 344% higher. Next slide. So this is that mountaintop that we just heard from Judy. This is the growth of physicians and the growth of the administrative managers in our healthcare system since 1970. And I think the graph speaks for itself. So I'll move on to the next slide. Now, this is another way to look at the administrative nightmare we've created in large part by having hundreds of private insurance companies dealing with thousands of claim forms. And this has as much to do with administering healthcare as denying it, all in the name of maximizing profits by private health insurers. When you look at Medicare, the 2020 Medicare Trustees Report had the administrative costs in Medicare at 1.3%. This compares to the administrative costs in the private sector, which runs about 12 to 18% per year. And the reason, though, there's that huge difference, a large part of it can be explained by a little bit by the next slide. Next slide, please. And this is another place where our healthcare dollars end up. This is the CEO compensation for 6 large private health insurers in 2020. And you can see on the top, Centene's CEO, Michael Neerdorf, was the highest paid chief executive among big national health insurers in 2020, earning $25 million. The median employee salary at Centene was about $69,000. So for a CEO to worker pay ratio of 362 to 1. Next slide. All right, so let's talk about New York. Many opponents of the Health Act argue, why should we blow up the whole system when only 5% of the people are uninsured? Well, first of all, this data is old and pre-pandemic. The number is surely higher now. Second, it's not even really 5%, because if you're talking about adults in New York before they reach Medicare age at 65, it's more like 8% of folks who are between the age of 19 and 64 with no health insurance. And we're still talking about 1 million people in the state. But I'd like to emphasize something else here, something that's often missed by pundits and the politicians in the media, which is that insurance coverage does not equal access to care. This is about an issue we call the underinsured, which Dick Gottfried mentioned and Judy mentioned. So let me just move to the next slide. This is one way of looking at the underinsured. It basically is people that are covered for an entire year with the health insurance, but their deductibles and their co-pays and are so expensive that they do not access care when they need them. So this is a survey done by the Commonwealth Fund in New York, and they defined it as they didn't fill a prescription, they didn't see a specialist when needed, they skipped the test, or they just didn't go to the doctor when they had a problem. And if we get to the next slide. Yeah, okay. So the next slide shows that under those definitions I just gave you, in New York, there's about 21% are underinsured. So if you add up the insured and the underinsured, we're now talking over close to 3.5 million New Yorkers, or about 30% of all New Yorkers who have inadequate access to care. And another study done in New York more recently, they found that 50% of New Yorkers didn't go for the healthcare they needed because of cost. All right, so now I'm going to talk about what I'm supposed to talk about, which are the costs of providing universal health care under the New York Health Act and how it's financed. But so to summarize, let me make a few points. To provide health care to all residents of New York with no co-pays, premiums, or deductibles without restrictive networks. So we're all free to choose our own providers. Oh, and covered too, and I'd like to emphasize in the New York Health Act are care for vision, hearing, dental care, as well as long-term care. All services, by the way, that are not currently covered under the Medicare program. If we cover all of that, it will still cost us no more than we're paying today, and probably several $billion less. How is that possible? Assemblyman Gottfried went through it. The answer is pretty simple. There are three main reasons, and others, but the three main ones are: we eliminate the wasteful, excruciating bureaucratic burden levied by the private health insurance industry. We use the leverage of 20 million New Yorkers to negotiate lower drug prices. And third, by removing the financial obstacles, we make things like providing primary care easier. People can get it earlier, and that prevents other costly expenditures. Next slide. All right, so this is a little background showing you the wealth distribution in the United States. But, and I'll get to that in a minute, but the short answer on how much will it cost under the New York Health Act and who will pay and how much will they pay, the short answer is that about 90% of New Yorkers will pay less than they're currently paying. The wealthiest 10% will pay a bit more, but let's remember that the extreme income and wealth inequality we're living through today. The top 10% of US households own more than 70% of the wealth, while the bottom half of the entire population own less than 1% of the wealth in this country. And in 2020 alone, during the height of the pandemic, the top 10% captured 70% of all new wealth generated, while the bottom 50% of the population captured about 4%. And there's one more thing, and this is more like a dirty little secret about the wealthy and employer-sponsored health insurance coverage in today's world. High-income families, those in the top 20%, actually receive a net subsidy to support their employer-sponsored health coverage equal to about $8,000 a year. And for the top 5%, it's closer to $12,000 a year. How is this possible? The answer is very, very simple, but not well understood. Under employer-sponsored coverage, both the employer and employee contributions to that coverage are tax exempt. The value of this exemption is in the order of $300 to $400 billion a year across the country. Where does this money come from? It is actually a line item in the federal budget, which means that all taxpayers foot that bill. Next slide. So this is a very broad overview of the cost of the New York Health Act. This slide was put together by Len Rodberg based on analyses done by the Rand Corporation on the cost and savings in the New York Health Act. And it basically shows you, it illustrates that we can cover everyone in New York with some modest savings. Overall, the savings on the New York Health Act due to the administrative savings and reducing drug costs, and the things on the left side, in red, costs go down about, the savings are around 18%. On the right side, the blue columns, the costs go up a little bit because we're covering more people that are either uninsured or underinsured. This is a good thing. And it's also including the costs of long-term care. Netting this all together, we have a savings of about 4%. But again, this covers everyone, no premiums, no co-pays, no deductibles. Next slide. This is another issue I just wanted to point out, not covered by the Rand Corporation in their study of this, I believe, but I think it's worth mentioning. In the New York Health Act, and Dick, you can correct me if I'm wrong, but in the New York Health Act, the local contributions to the Medicaid program which amount to about $7.4 billion a year, would be eliminated. This means that $7.4 billion currently paid for by New York counties, like Westchester or Rockland or et cetera, that 7.4 billion could be used to lower property taxes or pay for education or other services. So that's another savings that would accrue at the county level. And the final slide that people really want to know about is, well, what's this going to cost, and will it cost me more money? All right. This is a projected breakdown of the costs under the Act. Again, it's based on the RAND study and work by Len, Rodberg, and myself, and it's currently being updated. So the numbers may shift a little. These numbers are not in the bill, and Assemblyman Godfrey can speak to this if need be. But what is in the bill is and what he mentioned earlier is that it is based on progressive taxation with an 80-20 split between employers and employees. What I've shown you here is with a reasonable progressive taxation scheme, these would be the employee contributions at these various income levels. As again, as mentioned earlier, the first $25,000 is not taxed. There would be no employee contribution. If you're on Medicare, this is not on the slide. If you're on Medicare, it's a $50,000 cap, which there would be no contribution. And above that, these are the individual contributions the employee would make. And if you look on the right side of this table, which I've never seen anybody ever do before, at least in New York, is the percentage of income that those employee contributions consist of. So with 80% of New Yorkers earning less than 100,000, the median income is around 68,000. These are the current average employee premium contributions as of 2019, and they've gone up. So it's $5,100 for premiums that workers are paying out of their side, not what the employers are paying, what they're paying. The average deductible is $2,899, and the average maximum out of pocket is $8,300. So you can see that clearly 90% of New Yorkers would end up paying less under the New York Health Act than they are today. So can the top 10% pay a little more so that everyone has coverage in New York with no co-pays, premiums, or deductibles, and free choice of providers? Sure, they can pay what would amount to about 4% of their income for the coverage, and they should. After all, their health insurance has been subsidized by every taxpayer in New York for years. So we want to talk about income and wealth inequality and social justice. The bill that Assemblyman Gottfried has championed, along with Senator Rivera, is a social justice bill whose time has come. Thank you, and I'll just join in the questions when we're done. Thanks, everybody.
Thanks so much, Peter. I never thought about it, that statistic in terms of the before taxes price that you pay for your employer-based coverage and what that is robbing the federal government of in terms of taxable dollars is just an astonishing figure. And my guess is I'm not the only one who's sort of had that hit them in the face for the first time. And that among all the other sort of crazy conundrums that you've uncovered for us in the way that the system is engineered right now. We thought we'd do a couple of case studies just to get things rolling. And actually, I'm wondering, Liz, can you go just a couple of these, go to the fourth one, I think. Let's just start here because Peter, you brought this up and Judy brought this up. And so there's this huge administrative bloat that has grown over the last 30, 40 years relative to the number of healthcare providers. And part of what makes the New York Health Act work is that that bloat is removed. So no, can we go not to this one, to one just before it, please? Liz? Yeah, so what, one more? The fact of the matter is, I guess, is what happens to those people who have been in this administrative world. So somebody who, say, has been a claims specialist at United Healthcare or has worked for 20, 25 years as an administrator in a private insurer, for a private insurer, what happens to that tremendously bloated workforce once the New York Health Act becomes law?
So the question is somebody who now works for a health insurance company?
Sure. So someone who's
Okay.
working administratively in some
Okay.
aspect.
Well, first of all, that's out of 20 million New Yorkers, that's about 25,000 people. Now that's a significant number of jobs, and those are important human beings. But a couple of things. Number one is it doesn't make sense to have a healthcare system that seriously punishes 20 million people, both economically and in terms of their healthcare, as a jobs program for 25,000 insurance company workers. That just doesn't make sense. That's number one. Number two, any number of studies of state and national single payer models, including several studies like by the Rand Corporation of the New York Health Act, conclude that going to single payer puts so much money back in the pockets of workers and employers that it would generate about 200,000 jobs in New York State alone. So those 25,000 people who now work in the health insurance industry would easily find jobs among those 200,000 new jobs that would be created. So, A, it doesn't make sense to be damaging the family finances and the lives and health of 20 million New Yorkers as a way to create or to keep going 25,000 jobs, number one. Number two, we will be generating about 8 times that number of jobs by moving to the New York Health Act.
Mm-hmm.
Okay, let me just add one more thing. Dick, isn't there also something in the bill about a just transition for some of these workers?
Yeah, there is language in the bill that says that a portion of the New York Health Act Trust Fund can be used for things like unemployment coverage, retraining, relocating, et cetera, of workers. And that language, by the way, we wrote hand in hand with Local 1199, which over the years, because of all the disruptions in the hospital industry, has gotten very skilled at the whole issue of retraining and relocating employees when their jobs are lost. So 1199 worked with us to create that language in the bill.
Great, thank you. Peter, anything else to add to that?
To that particular point, no, I think I knew Dick would take care of it. I just want to make sure he talked about the just transition.
Okay, great. Liz, sorry for being so poor in my direction. Why don't we go back to the first case study? Thank you so much. One more, I think. So we're wondering, and again, we just put this up there to broadly kind of give some amplification to a lot of the things that Assemblyman, you and Peter talked about. What does this mean for the life of and the lives of undocumented people in the state of New York? So if there's a family, for the folks who are undocumented, they work in the restaurant, they have health problems, where are they now and where will they be under the New York Health Act?
They're in really, really deep trouble now. because they probably have no health coverage as restaurant workers. And because they're undocumented, at least the adults in the family have no health coverage. The kids are probably eligible for Child Health Plus, but only until they turn 19. And Child Health Plus, like Medicaid, does not really pay the full cost of care. And so not only is this family in deep trouble financially and health-wise, but the doctors and hospitals where they show up on the doorstep of their local hospital, that hospital is in trouble because they're probably not going to turn them away. But they have really no way to get their bills paid. And so whatever hospital in Westchester they show up at, that hospital is going to be seriously financially hurt when they show up. And that's going to do a combination of stretching thinner and thinner the care that any patient who arrives at that hospital is going to get. And it means that even that patients who show up with good health coverage, in quotes, a large part of what their health plan pays is going to be subsidizing the hospital for taking care of the patients who have no way to pay for their bill. And under the New York Health Act, all of that goes away. The people who now have health coverage will continue to be fully covered by the New York Health Act. The hospital will be saving an enormous amount of money by cutting out the outrageous amounts they now spend on administrative costs to fight with those insurance companies. And the patients who arrive at the hospital with either no way to have their bill paid or have their bill paid very inadequately by public health coverage, which we all know doesn't fully cover the cost of the care, everyone who walks into that hospital under the New York Health Act will be fully covered and fully and fairly paid. So the patients will be a whole lot better off, their families will be better off financially and health-wise, and their doctors and hospitals and nurses and physical therapists will all be a whole lot better off than they are today.
Great, thank you. Peter, any comments on that? Gotcha. Liz, can we go to the, I think it's the last case study, please? Yes. So, Assemblyman Peter, let's look at it from this perspective, from maybe a provider's perspective. So someone who is, can we go back to the slide just previously? So say an acupuncturist who has a private office and employs some other providers and office staff. They're typically, out of network with major commercial insurance companies. The Health Act, so where are they now, right, in terms of keeping their shop running, and how will they be affected? How will this independent healthcare provider be affected when the New York Health Act passes?
Well, today, a lot of health coverage, I think, does not cover acupuncture. So the acupuncturist is dependent on people who have enough personal wealth to pay them out of pocket. Under the New York Health Act, acupuncture would be a covered benefit. And it would be guaranteed to be a benefit that covers costs and is adequate to assure an adequate supply of the service. Guarantees that exist nowhere in our system today. On the other hand, the acupuncturist will be able to put his or her resources into providing acupuncture and related services and will not have to spend an enormous amount of money on staff to fight with insurance company bureaucrats, which doesn't do their patients any good at all.
Yeah, great. And Peter, there's one I'd like to go to quickly. I think, Liz, it's two back from this one. Right, one down. You went one past it. Sorry, we didn't work this out before, people, but you know, a little improvisation never hurt anybody. So, Peter, this reminds me of the chart and the slide that you put up in terms of what percentage of their income people will be paying with the New York Health Act versus what they might be paying now. So you've got someone who's self-employed, who has some complex medical problems, earning $200,000 and potentially paying $25,000 to comprehensively cover his whole family, still have deductibles, probably still have copays. Just want to get your comments on a situation like this and what the Health Act will do for someone who's in a situation like this.
Well, we'd have to go back to the actual slide, which I don't have in front of me, in terms of what someone in a $200,000 bracket would be. But remember two things about this. Just like with Social Security, when you have an employer-employee, you know, sharing the burden of the Social Security payroll tax, the FICA tax, similarly in the New York Health Act, if you're self-employed, you would pay the full amount of whatever the employer plus the employee paid. The only so you would have to do the math to figure it out exactly, but the only other point I would make is if he's self-employed, it's not the salary per se, but it's the net income, which would you would deduct from the income all the expenses of running that business, right? So rent and employees, etc. So it would be the net income that would be taxed. So you'd have to do the math to figure it out, but that's essentially how it would work.
Yeah. So yeah, I really appreciate that. It's a more complicated math problem. I think on your slide it was something about if you were in the 225, it was like 3 or 4%, which I think is far less than he might be paying if we did the math on his.
No, but let me be clear. That's not no, you have to do more math because that is assuming an 80-20 split between employer and employee. So if you would have to go, it would be considerably more because it would include 100%.
Gotcha.
A couple of other numbers to keep in mind. Remember, this says that the family insurance policy has a $2,000 deductible, which, if we know anything about it, is going to be a whole lot more next year because that's what happens with deductibles. And then there are copays and out-of-network charges. And based on the clinical information you gave us about the guy, there's a very good chance that at some point in the near future, he or another member of the household is going to be needing home care or nursing home care. And that's going to wipe out a lifetime of family savings. I know that from personal experience with my mother. It's going to wipe out everything they've saved. Or some other member of the family is going to have to give up a large part of her life or her career. And as I said earlier, in our society, it's almost certainly a her, not a he, to care for that family member. Under the New York Health Act, that goes away. Because under the New York Health Act, if the father with his COPD and hypertension, et cetera, needs home health care, which is a fairly safe bet, it'll be covered.
Excellent, excellent. I'm going to bring Eileen O'Connor up here, one of the leaders of NYCD 16 Indivisible. And what we're going to do is move into some questions. Obviously, we fielded a tremendous number of questions prior to the event, and the chat has been absolutely chuggy jam. So I'm going to hand it over to Eileen to ask a couple of questions of our wonderful panelists.
Okay, thank you, Andrew. Let me just get to that. or I have to scroll back up. Sorry, I'm overshooting here. Sorry, I should have put this in. Can somebody else start?
I can start it.
Yep, thank you.
Okay, can everyone hear me? Okay. We have
Thanks, Judy.
Okay, we have a three-part question concerning Medicare. The first part is many retirees, like teachers and government workers, have Medicare as primary coverage and secondary insurance as part of a state or municipal retirement plan. How would the New York Health Act affect their health benefits? Do you want to answer the questions one at a time, or shall I say them all?
Well, I'd go one at a time, yeah.
Okay.
Okay. If they, as a public employee retiree, if they live in if they remain as residents of New York, they would be fully covered by the New York Health Act, which will give them dramatically better health coverage than their current package, and without having to pay deductibles or whatever else may be scattered through their current package. If they move out of state, they would then have their Medicare that would travel with them. And if their public employee retirement coverage covers them out of state, that too would carry with them out of state. So if they leave New York, they would have at least the current package they have today, and the bill spells that out. If they remain in New York as residents, then their coverage would be way better and richer than what they have today, including as retirees, the fact that they would now have coverage for long-term care, which retiree health benefits do not cover and Medicare does not cover, would be enormously valuable to them.
That's great. And so there would be no need for a secondary insurance?
Absolutely not.
Got it. Judy, I found my,
great.
I need to go. Thank you. Thank you for pitch hitting. The second question is, how would Medicare benefits coordinate with New York Health Act benefits for seniors 65 and over who've been contributing to Medicare for over 40 years? Would Medicare stay separate because it's federal, or would the Medicare funds be absorbed into the New York Health Trust Fund? What would be the process that seniors would go to in using both plans?
Yeah.
So I think you need to explain what the whole pot that
well, the answer is, first of all, for people who are enrolled in Medicare, remember their first $50,000 of income every year would be completely exempt from the New York Health Act taxes. And that's in recognition of the fact, largely of the fact that they would be drawing down a big chunk of Medicare money into the New York State healthcare system. Exactly how, there are several ways that the New York Health Act would merge with Medicare. And again, stress that every Medicare enrollee would continue to have every right and every benefit they now get from Medicare and even more. And that's guaranteed A, by federal law, and it's spelled out explicitly in the New York Health Act. But on top of the rights and benefits they have under Medicare, the New York Health Act, at the very least, would essentially be a wraparound around their Medicare coverage. So the gaps in their Medicare coverage would be filled in by New York Health. The inadequacy of their payment rates under Medicare would be supplemented by New York Health. Long-term care would be provided by New York Health. Now that's if Medicare does not cooperate with New York at all. If Medicare is smart and wants to be efficient and save money, they would work with New York to pay to New York every year an amount equal to what Medicare would have paid into New York anyway. They would put that into the New York Health Act Trust Fund. It would all be rolled into one with the New York Health Act Trust Fund, and Medicare enrollees would be covered by New York Health without the mechanics of wraparound, et cetera, et cetera. Either way, every Medicare enrollee would get dramatically more benefits than they have today at lower cost, thanks to the New York Health Act. So there are a couple of possibilities of the mechanics, depending on how intelligent the federal government wants to be about working with us. But however it works out, New Yorkers on Medicare would be making out far, far better than they are today. And that's guaranteed in black and white in the bill.
Gotcha. Thank you. The New York Health Act
I would just
requires.
add,
Oops, sorry, Peter.
Eileen, I would just add two things to what was just said, just to lay it out. There would be no need under the New York Health Act for supplemental Medicare policies.
Right.
No need, because of the rich array of benefits afforded to them. And just to be explicit again, what's not included, the big ticket items not included under traditional Medicare today are hearing services, vision services, dental services, and long-term care. Those are all covered under the New York Health Act.
Right.
And drugs.
By the way, Statewide Senior Action Council is not only today one of the most active groups supporting the New York Health Act, they were one of the groups that 30 years ago sat me down and said, Gottfried, we need to explain this single payer thing to you because this is what you need to be for. Statewide Senior Action Council was one of the groups that brought me on board. Now, some people might ask, oh, what about AARP? Well, AARP, if you ask them, and I have, will sort of sheepishly say, no, we're not going to support the New York Health Act. Why? Because the AARP is largely funded by the Medicare supplemental plan that they sell. So yeah, AARP is not about to support the New York Health Act. They make too much money selling health insurance.
I think this is a quick answer. And then I think Andrew wanted me to do something which I need to check my text for. The New York Health Act required people to use doctors in New York State. The closest hospital to me is in Greenwich. Many people in our community go there for care and use doctors in Connecticut. How will this work
Guess
for
what?
people
We
who
thought
use?
of that.
Excellent.
The answer is under the New York Health Act, if you are, the New York Health Act will pay for out-of-state care under two basic circumstances. One is if you are temporarily out of state, like if you're hiking in the Grand Canyon and you break your leg, New York Health Act will pay to a doctor or a hospital in Colorado or wherever the Grand Canyon is to fix your broken leg. Duh. Number two, there are a lot of places in New York State where the nearest doctor or hospital is across the border. You know, my family used to have a house in Dutchess County, and if you went to the doctor or if you had to go to the local hospital, you went across the border into Sharon, Connecticut. So I'm pretty familiar with that. So the New York Health Act says if you go out of state, because it makes sense medically to go out of state to a doctor or a hospital, the New York Health Act will pay. And if that doctor, you know, chooses to be can choose to be a participating provider in the New York Health Act, because we're open to any participating provider, that would make it even easier for the doctors and hospitals in Greenwich, Connecticut to be part of the New York Health Act. And, you know, finally, you know, if you live in Jamestown, New York, which is a whole lot closer to Cleveland than it is to Albany, if you need fancy open heart surgery, you're probably going to go to the Cleveland Clinic, not a hospital in New York State. And the New York Health Act says if you're going out of state because it's medically appropriate, we'll pay for you to go out of state, period. So all of that is covered in the New York Health Act in very clear and very strong language.
And that would cover New York State resident students who go out of state for college?
Yes, as long as they're a New York resident, their medical bills would be paid for, wherever they incur them.
Okay, great. Thank you. We're getting close to the time to just ask one last question. This year, it seems like there's a real momentum to get this act passed. We understand that the Healthcare Act is not on the agenda in the Senate Health Committee tomorrow. Do you know if that has changed? And if it doesn't get brought up in their committee tomorrow, what happens?
Well, I do not know the current situation with the Senate Health Committee agenda. The Assembly Health Committee reported the bill, I don't know, about a month ago. But in the Senate, they report bills, constantly right up to the very last minute of the session, whether their committee has had its last meeting of the year or not. They're a little more flexible on that kind of thing in the Senate.
Could you say more about what report means?
Oh, to report a bill out of a committee means to send it to the floor for a vote.
So if the Healthcare Committee is not going to have this on their agenda tomorrow,
It can still be brought out of the committee onto the floor.
It can still be brought out of committee onto the floor. Okay.
It would have to go through, it goes through the Rules Committee, is that right, Assemblyman, in bypassing its own committee?
Technically, yes. And the Rules Committee in both houses is really a body for expediting a bill to the floor.
And do you want to, just as we close and we have 1 minute, just share with us your prognosticating about whether or not it's going to make it to the floor and we're going to see it voted on?
Well, was it Yogi Berra who said that predicting is very difficult, especially about the future?
Well, he also said it ain't over till it's over.
You got it. And all I can say is we are in a better position than we've been in a long time, because we have the largest majority in the Assembly co-sponsoring the bill than we've ever had. And in the Senate, for the first time, we have a majority of the Senate co-sponsoring the bill. That's a pretty good place to be in.
And I guess, we could end by asking, another maybe unanswerable, but should it come to the floor and should it pass and it need to be signed into law? Thoughts about that?
Well, Gustavo Rivera, the Senate sponsor, and I are assuming that when it becomes clear that the bill is about to pass both houses, he and I will get a very insistent phone call from the governor's office telling us to get our ass down to his office in the next 20 minutes. We have to talk. And so we've been preparing for that conversation. I've had a couple of conversations like that in the past, and we're ready for that conversation. And I don't know what amendments this governor might want. I do know that Andrew Cuomo has in the past said that he thinks single payer is the most sensible way to pay for healthcare. He believes it's better done at the national level. Well, of course, and if I had a magic wand, it would be done at the national level. But on the other hand, like almost all progressive social legislation in this country, it begins at the state level, and more often than not in New York.
Well, thanks for that, and thanks for sharing that with us. And we're behind you when that phone call comes. That's going to be an awesome moment, I'm sure, and one that means that potentially we're close as we've ever been before.
Yep.
So on behalf of Eileen and myself and all of the other co-sponsors, we want to thank you, Assemblyman Godfrey. We want to thank you, Peter Arno, for being with us. We're heartbroken that Gustavo couldn't make it tonight, but we know he's out there somewhere, the fighter that he is, likely fighting for this legislation. People who are here with us, thank you, 40 strong, who joined us tonight. These last two slides do give us some actions now to turn to. So please take pictures of these slides. so that you can get involved in actions. Please, we need to let the Senate know that this is important and we want this moved through committee and we want this moving to the floor for a vote. So please let the majority leader, who is all of our representatives, but certainly many of the people who are on this call, Leader Stewart Cousins, may be your representatives. So please, let's let her know that its time has come. And again, we thank you for all the work that you've done, Dick, in moving this and in crafting this legislation and getting to this moment where we are right now.
Well, thank you for everything you're doing on this.
You know, for those of us who were on Twitter, if you can, you know, use the hashtag here and send a tweet to Andrew Stewart Cousins, Senator Rivera, the New York Health Campaign. We want the New York Health Act on the table, want to vote in the Health Committee tomorrow, so that we can get a bit of a momentum going there from this meeting tonight. Thank you.
Thank you.
Thanks so much for joining us. Thanks, Peter. Thanks so much to everyone who hopped on and joined us tonight. We look forward to seeing you on the ground soon.
Good night.
Good night.
Good night.
Hello, everybody.
How are you?
Hello, Caroline.
Hey.
Glad you're able to come on.
Hi, Caroline. Just got back.
Welcome back.
It was amazing. My parents behaved.
Oh, excellent.
If I save the chat, where will it show up?
I'm trying to find out.
Oh,
I'm going to stop the share.
Oh, and we should stop the.
I gotta stop recording.
Yeah.
Yep.
Good idea.